Second. All right. Thank you, everyone, for coming to the Tri-Divisions of Emergency Medicine Regional Rounds. Today's date is Thursday, June 24th, 2021. We have an amazing guest on today to give us a great update on Lyme disease management. And that is Dr. Eva Piessens. She is an associate professor in the Department of Medicine and is the program director for the infectious disease residency at McMaster University. She did her medical residency and infectious disease training at the Beth Israel Deaconess Hospital in Boston, Massachusetts. She worked at hospital affiliated with Georgetown University, Washington, D.C., and Tufts University in Boston, Massachusetts as well, prior to joining the McMaster divisions of infectious disease in November 2012. Dr. Piessens is interested in education, infection, and immunocompromised host and Lyme disease, and we are very honored to have her on with us today. So without further ado, please go ahead, and the floor is yours.
Okay, thanks very much for the invitation. In terms of my Lyme credentials, I did practice in Massachusetts for about 10 years between Washington, D.C. and here. And so I can safely say that I've probably seen hundreds of cases of Lyme. So I do speak for some personal experience as well as academic experience. So I'm happy to be interrupted if something doesn't make sense to you guys. I'm happy to chat at the end as well. I have nothing to disclose. So what I'd like to do is just sort of put us all up to speed in terms of what the current Lyme epidemiology and transmission is, assess the risk of Lyme transmission after a tick bite. We'll talk very briefly about common clinical manifestations and then delve into kind of the use and interpretation of Lyme serology in the context of clinical stage. If we have time, we can talk about the definition and controversy over what's called chronic Lyme, because I think that's where issues around testing and distrust of the Canadian Lyme testing comes into play. So Lyme is actually a relatively recent illness, I suppose. And when I say Lyme, I'm really talking about infections due to Borrelia burgdorferi, that would be North American Lyme, and less commonly with European species called Epstein-Barr and Carinii, which I'll get back to. But you know, it was two moms, one of whom, Polly Murray, called the Connecticut Public Health Department in 1975, and they sent out a rheumatologist because there was a question of arthritis, and he found 39 kids, 12 adults, who had what was being called rheumatoid arthritis, and heard about this rash, and that sort of set the stage for first a clinical diagnosis, and then in 1982 a microbiologic diagnosis for what we now call Lyme disease. And Lyme, being first described in the US, is what we call hyperendemic in the Northeast US and in the upper Midwest. And hyperendemic means that about 60% or more of the nymphs are actually infected with Borrelia. As I'll show you, Borrelia is transmitted through the Ixodes tick, which is a black-legged tick. From Northeast US, the ticks and therefore Lyme disease have sort of spread north and west along rivers. So they're carried on birds, they're carried on deer, they're carried on mice, and they slowly but surely have moved northward and westward. And so there's several regions in Ontario, no longer just southern Ontario. I guess technically it is still southern Ontario, but going as far north as Toronto, into the Muskokas, in Ottawa as well. Now, these are established tick areas, which doesn't mean that they all have Lyme disease, but we know that where the tick areas are established, Lyme follows. The other thing I want to point out, though, and we'll come back to it when we talk about testing, is that Lyme is really probably a worldwide illness. We don't have any data from South America or Africa because it's not screened for. But in Africa and Asia, there are two species of Borrelia called Epstein-Barr and Carinii that can cause arthritis, although less commonly than burgdorferi. They can cause skin changes, and they can cause CNS symptoms, which we'll get back to. So really, Lyme's global disease. You need to think about it as a traveler's disease as well as a local disease. In 2018, on average, 2.7 per 100,000 risk in Canada, 37 per 100,000 in the USA, most of those from the Northeast. And depending on where in Europe, 10 to 100 cases per 100,000, it tends to concentrate in Central and Southern Europe where there's a lot of woods. But I've diagnosed people with European Lyme who went to Ireland for the summer, for example. So I don't think geography can exclude it at this point. So as I said, Lyme is transmitted through the black-legged ticks, and the ticks are not born infected. Eggs are laying. They grow from larvae into nymphs. This is where they start becoming infected by feeding on either small mammals or in birds. Larvae don't tend to bite humans, and so we tend to get infected if we come across an infected nymph or an infected adult. And makes sense that most of the cases in Canada through 2015 were diagnosed in the spring, summer, winter, early fall months. This is when ticks are most active. But you need to realize that you can actually present with acute Lyme in December if there's a little local microenvironment where where it's still warm. So ticks do not become dormant until it's below 0 for several days in a row. And then obviously you can be diagnosed with later stages of Lyme, which can occur anywhere from weeks to months after your tick bite, well into the winter. And so Lyme doesn't fully go away just because it's colder. So we get, I'm sure you guys get this call as well. We get a frantic mom calls you because she's found a tick on her 7-year-old's back at bath time. Her daughter's been outside most of the day, including playing soccer in a field near a wooded area. But she's sure that it wasn't there when she dressed her this morning. So this tick has been embedded for about 8 hours, say. And she wants to know whether or not her daughter should be tested for Lyme or whether her daughter should get antibiotics for Lyme, right? And so what are the questions to ask? One is it a deer tick? These are tick submissions to Niagara Public Health, but really applies to most of Ontario. And you'll see that overwhelmingly, the number of ticks that are submitted for identification are actually dog ticks. Dog ticks do not transmit Lyme disease. About 10%, maybe a little higher, are black-legged ticks. And so if you can identify the tick as a dog tick, you're done, right? You're not worried about Lyme at all. If you can identify it as a Ixodes tick or black-legged tick, and these are kind of the difference. So deer tick, black legs, sort of black back, if you want, adult male, adult female, nymph, male and female. And these are in contrast with the wood ticks or the dog ticks, which are brown, with a lighter back. So the next question is, what's the chances of that tick actually having Lyme disease? Because even if you're bitten by an Ixodes tick, if it doesn't have Lyme, you're not going to get Lyme. And I'll show you how it's transmitted in a minute. And again, data from Niagara, we can take it with a grain of salt, but you see from 2015 to 2019, somewhere between 11 and say 20% of ticks were positive for Lyme disease. Now, there are certainly veterinary studies of dogs where they intimate that up to 50% of ticks might have Lyme disease. These are deer ticks biting dogs. And the local epidemiology is going to really vary. So although you may have more ticks in a heavily wooded area, in New England, for example, you can get Lyme going to Central Park, right? And Lyme has actually been described as being transmitted from parks in Toronto. So the local epidemiology is going to vary a bit. But I think we're probably on the order of somewhere between 20 and 30% of nymphs being infected with Lyme in Southern Ontario at this point. And then the last question to ask before you decide to do anything with this kid is, how long was the tick embedded? And so for us ID nerds, Borrelia actually hides out in the hindgut of the tick. When the tick takes a blood meal, the temperature goes up, oxygen goes up, and that sort of changes the Borrelia from its static phase to its active phase. It migrates to the foregut and it essentially gets regurgitated onto your skin and comes into the puncture wound where the tick is feeding. And these ticks will feed anywhere from 12 to up to 5 days. So they're slow feeders. Once it gets under the skin, it will disseminate, and it's that dissemination that causes the initial rash that we look at. That process, hindgut to foregut to regurgitation, takes probably 36 hours, but certainly based on that mathematical model, a minimum of 24. And so for this particular, for this particular case, since the tick has been there for less than 8 hours, at most 12 hours, we can comfortably say there's nothing to do. There's no need for prophylaxis. There's no need for further testing. Now, this kid is going to be, playing in an area where there are Lyme ticks. And so, daily tick checks are going to be very important, because just because she didn't get Lyme from this tick doesn't mean she's home free, but this particular exposure is not meaningful. How do you tell how long the tick has been there? I mean, obviously, if you sort of looked at the area earlier in the day taking a shower and it wasn't there, that's something. The other is just how engorged this is. So this top layer is the nymph, and you can see it kind of goes from a sesame seed to something that's a little bit more visible in 4 days. This is the adult unfed all the way up to day 7, where it's kind of huge, right? And so I don't know that it's helpful on an individual person, but sometimes asking how big was it? And, if you squished it, how much blood came out? People can get very graphic, is helpful in trying to figure out, okay, it's really only been there for 24 hours or less, or it's been there for longer. And it's that mathematical modeling that has led to the recommendations for chemoprophylaxis, right? And so chemoprophylaxis is recommended if it's an Ixodes scapularis tick, if it's occurred in a highly endemic area. In the study, it was defined as nymphs being more than 20% positive, which I think in some places we've achieved, and the tick has been attached for more than 36 hours. For those folks, you could consider doxycycline 200 milligrams once. This is before the rash, before they have any symptoms, or amoxicillin for 10 days in kids. You do want to start within 72 hours of tick removal, right? So starting at a week later is really not going to buy you much. So for our case 1, this is really a low risk exposure. This tick was only embedded for 8 to 10 hours. And as I said, there's not much to do except reassurance at this point. What about early disease? So this is a case that I saw a couple years ago, 25-year-old woman from Long Point, which is an endemic area. And she presented with a 7-centimeter oval lesion, but it was vesicular in the center. It had blisters in the center. It had been, however, slowly but surely increasing in a somewhat circular fashion over the last 3 days. And her family doctor sent her to me because the appearance was atypical to her for an EM rash. She didn't recall a tick bite, but her partner had picked off a tick on their return that was identified as a deer tick. Should you wait to treat until you get a positive antibody test? So Lyme is really it has 3 distinct phases. So it starts with the rash, that's the point of contact. It may disseminate and cause disseminated disease, and that can be multiple EM rashes, a flu-like illness, carditis, or aseptic meningitis. And then if untreated, it can then sort of coalesce into a single organ system, which in the North America is usually arthritis and less CNS disease. In Europe is more CNS disease than arthritis. Okay, and so knowing that time frame from initial exposure to dissemination and then back to a late point is important. The EM rash can take on average 7 days, but it's been described as high as a month after a tick bite or an exposure. Dissemination can occur at 2 weeks all the way up to 3 to 4 months. And then late disease can occur weeks to months, sometimes years after an exposure. Note, like syphilis, that the stages can overlap. So you can have your EM rash and present with an aseptic meningitis at the same time, in the same way that you can have your primary chancre and have a diffuse rash of syphilis. And so stage is really a clinical sort of diagnosis. As I said, both North American and European strains can cause erythema migrans. They can cause lymphocytic meningitis, so your aseptic meningitis, which may or may not have cranial nerve palsies. They can cause Lyme arthritis and carditis, all three of them. European Lyme also can cause some specific skin changes like a lymphocytoma or acrodermatitis chronica atrophicans, which is really chronic neural inflammation causing skin damage in a stocking glove distribution. So some overlap in clinical syndromes. On Ontario, complicated slide, I apologize, but this is sort of a review from 2005 to 2014 of how people presented. I think it's changed a bit. I will point out that about 40% presented with early disease. So this is the rash. I would expect that with familiarity of what the rash can look like, that percentage is actually going to go up. And that's what happened in New England. As we became much more familiar with an EM rash look like, we caught more people early, fewer people disseminated. In Ontario, it was about 20%. And many fewer people with late disseminated, particularly the arthritis. So in 2005 to 2014, it was about 40% of people who had Lyme presented with Lyme arthritis. If you look at more recent literature, that's actually down to about 2 to 5% because of recognition of earlier disease. They talk a little bit about the EM rash. So about 87% of people with early localized were identified because of the rash. But look at this, about 60% of them had their flu-like illness at the same time. That went up to about 90% in early disseminated and was maintained for late disease, which is a bit atypical from studies. So it tends to be local, disseminated, and then local again to a single organ system. Before we talk about sort of clinical disease, it's very important to understand how the testing is done. And one comment I hear over and over again is testing in Canada is not as reliable as in the States. That's actually not true. So the testing that public health does is the testing that was defined and modeled at the CDC in the US, and every single publicly funded or government funded lab in the US does exactly the same two-tier test. What this test does not talk about, and we can come back at the end, are what we call private labs. A key one is IGeneX. There's another one called Orman Labs in Germany that bill themselves as Lyme literate. They do a whole litany of other tests and interpret them differently. The big issue, I think, from an ID viewpoint with those labs is they've never allowed their methods to be validated by others. So we don't know if they're reproducible. We don't know what they mean. So what most of the US and public health will do is they'll do a screening ELISA. Okay. If the ELISA is positive or equivocable, they will then do a Western blot. And really, they always do the IgM and IgG Western blot for Lyme disease. takes about up to 4 to 6 weeks to develop your ELISA. It takes roughly 6 to 8 weeks to develop your IgM and about 8 weeks to develop your IgG. So again, if you look at the literature, somebody who's had symptoms for more than a couple of months, who has a persistently negative Western blot, particularly the IgG Western blot, does not have Lyme disease. The only other thing you should know about the testing is the ELISA will capture infection from Borrelia burgdorferi and also the European strains Borrelia guarinii and Afzelii. There's a shared protein, and that's what the ELISA looks for. But it will, the Western blot is specific for Borrelia burgdorferi. So if you have somebody with chronic CNS symptoms, a positive ELISA but a negative Western blot, you can request a specific European Western blot, which goes to Winnipeg, and that will give you whether or not they've been exposed to Afzelii or guarinii. Are there any questions about the two-tiered testing? Because that is important, and we will come back to it. I just want to make sure that my explanation was clear to people. Okay. So manifestations of Lyme disease. Early localized disease is the single erythema migrans lesion, and that's present in about 80 to 85%. Now, you may not see it. The ticks like sort of moist, warm area, so it might be the back of your knee, it might be the armpit. It's been reported as soon as 3 days after a tick bite and as long as 30 days after a tick bite. Stage 2 is early disseminated disease, again, a week to about 6 weeks out. It can be multiple EM lesions. It can be early neurologic Lyme disease, which tends to be inflammatory. So it's a Bell's palsy with or without an aseptic meningitis. And it can be Lyme carditis in about 5%, which can present as a variety of heart blocks, including complete heart block or myocarditis. So one thing from an ER perspective, I suppose, when do you want to test? You certainly want to test if you have clinical suspicion that this is early disseminated disease. So a young person with complete heart block is a bit atypical. Maybe we want to do our Lyme disease. Somebody with Bell's palsy, now statistically it's going to be HSV or idiopathic, but particularly if they have aseptic meningitis, you do want to make sure that you're not missing Lyme disease for them. These are various pictures of erythema migrans. And up here, this is your classic bullseye rash. So you've got your center, you've got clearing, and you've got the migratory border. This is Borrelia sort of moving. And again, they're moving in all directions. And so to kind of decide whether this is cellulitis or not, this, you might wonder cellulitis, but it's oval and it's growing in all directions as opposed to going up and down lymphatic systems. It can ulcerate, it can blister, it can look like what's been described as a spider bite. It can be very difficult, and I'm sorry the pictures aren't great, very difficult to ascertain on darker skin, and there's good literature to suggest that in the US, African Americans are about 60% less likely to be diagnosed with primary Lyme disease because of this. So this is a very subtle sort of bite with some mild erythema around it. This guy had a bite and almost discoloration that was going circular. Again, hard to establish. And so classic is great, but classic in ID is not usually the most common, and you need to have a fairly low index of suspicion. I'm happy to, well, this is being recorded. So just in terms of differential diagnosis, things like cellulitis, granuloma annulare, spider bite. Again, the key with Borrelia is that the Borrelia are migrating through your skin. And so a rash that's expanding 2 to 3 centimeters a day, which is atypical for a lot of these other things, should really bring that to mind. Testing in stage 1 or early stage 2 is lousy, right? So two-tier testing has sensitivity of about 29, so 30 to 40% at best. Again, it mimics syphilis. Somebody coming in with a primary chancre has about a 50-50 chance of having a positive RPR. And so the teaching is that if you have somebody with a characteristic rash and the right epidemiology, there's actually no point in doing serology. You should go ahead and treat, right? And so for case 2, she has the right risk factors. She has the right rash. It's growing over the last 3 days. She should be treated, and ideally with doxycycline unless there's a contraindication. The role of antibody testing becomes much more important in later disease. So this is a gentleman with right knee pain, swelling and warmth worsening over the last month. It's a subacute septic arthritis, and it's one joint. He does have 18,000 white cells that are neutrophil predominant. There are no crystals. He cultures and PCR are negative, and he got 4 weeks of empiric cefazolin before we were asked to see him, and he's no better. Okay. Late Lyme disease is often indolent. So the Lyme arthritis is monoarticular or oligoarticular. One important thing is it tends to be large joints, so it's knees, ankles more commonly. Small joints like hand arthritis would be very, very, very atypical for Lyme disease. Late neurologic Lyme disease, you should think about it as tertiary syphilis. So it's mild but objective cognitive abnormalities, early Alzheimer's in somebody who's a bit of an atypical person. It can also present as peripheral neuropathy, so a stocking glove distribution. And this is where, again, although other things are going to be much more common, an antibody would be really helpful in managing patients. I alluded to briefly, and I'll skip this in terms of time, but arthritis is much more common in the North American strain, and the radiculitis, neuroborreliosis is much more common with the European strain. So in people who've had cognitive dysfunction, or what they describe as brain fog, and have any history of traveling to Europe, it's definitely worth ruling out Lyme. I've diagnosed probably half a dozen people now with European Lyme neuroborreliosis, and they do improve with antibiotic therapy. So it's important not to miss the diagnosis. These are the two manifestations. So this is a Lyme lymphocytoma, again, European Lyme. It's a collection of lymphocytes causing this hypervascular lesion. And this is the atrophy. This is actually the hands of a 25-year-old woman, and you see all of the damage, and that's because of chronic nerve stimulation. So 2 clues on exam that should make you think about European Lyme. When you look at the performance of the testing, you'll see that the 2-tier testing really increases. And so stage 1, not great. Recovering from stage 1, better, but not great. And sometimes you can actually treat an EM rash and they don't develop an antibody because you've removed the immune stimulus in time. With neurologic involvement, and this is both secondary and tertiary, you go up to about 90%. And then with arthritis, which is really tertiary, you go up to 97 to almost 100%. Now, are there issues with 2-tier testing? Yes and no. So it is in part a mathematical model. For the lab to call an IgM positive, you have to have 1 of 2 bands. For them to call an IgG positive, you have to have 5 of 10 bands. So what we don't know is if you have a positive ELISA and 4 bands, do you really have Lyme disease or not? There's actually a study going on with Kingston as one of the sites looking at the specific bands in correlation with stage of disease, and hopefully we'll get an answer there. There's a lot of cross-reactivity with IgM bands. Anything from syphilis to the flu can give you a false positive IgM. But I think on the whole, particularly for later stages of disease and the arthritis, the negative predictive value is actually excellent. despite what Google would have you think. So this gentleman, we did do a Lyme antibody. You can also ask for a Lyme PCR, but I think that's less helpful in terms of its sensitivity. He had a positive antibody. He was actually treated for Lyme with doxycycline and improved clinically. The one sort of clinical clue that this might be Lyme arthritis as opposed to septic arthritis is that the effusions seem to be much more prominent with less inflammation. So more swelling, but less erythema may make you think about Lyme disease. Treatment is very well established for erythema migrans, doxycycline, usually 7 to 10 days. I tend to treat longer if there are multiple EM rashes, so they're sort of in that second stage, or if there's significant flu-like symptoms, because I think that's sort of implies early dissemination. Meningitis or radiculopathy, so Bell's palsy, again, doxycycline would be first line. Initial treatment of arthritis would be first line. The only time you might want to consider ceftriaxone or IV therapy up front is if you have carditis with a complete heart block. There's anecdotal evidence that ceftriaxone may reverse the heart block a little bit faster than the doxycycline does. So post-Lyme syndrome versus chronic Lyme. Again, a patient who presented in my clinic several years ago, 62, from Hamilton, had a remote history of tick bites, and presented with several months, up to 6 months, of progressive fatigue, myalgias, cognitive dysfunction, or what she called brain fog. Her public health testing showed a borderline ELISA, a positive IgM Western blot, and a negative IgG. And remember, she had more than 8 weeks of symptoms. And so if she had untreated Lyme, we would have expected her IgG to start turning positive. If you're not sure, repeat it in 4 to 6 weeks and see if there's any progression in the pattern. Hers had actually been repeated before she saw me, and there was no progression in that pattern. So that pattern was pretty stable. She had gotten testing from IGeneX, which is a private lab in California, and was labeled as having Lyme disease with several co-infections. And some of the tests that they commented on was a CD57, a positive IgM with one positive band. Again, you need to have one of two, but there's a fair amount of cross-reactivity, and a positive IgG with 3 bands, but she had a negative ELISA in that. And so this sort of constellation of testing is uninterpretable, both because it falls out of the modeling and validation that the other testing is done, and because we really don't know how they're doing these tests. IGeneX is one of the labs that's never allowed anybody to look at their methods. She really wanted IV therapy. Again, your antibody positivity, your serology is going to increase with chronicity. By history, she would have been late disease. By antibodies, she could have been early disease. And so there's a major disconnect between those two pieces of information for her. This is just one study done out of Ontario. And again, busy slide, but this is somebody who took it upon himself to send blood work from 40 completely healthy people, no clinical concern for Lyme disease at all. And it was sent to a university reference lab, a commercial lab, a specialty lab, and specialty lab B, which rumor has it is IGeneX. Just look at the different rates of positivity for the ELISA, so 2.5 to 12.5%. Some discordance for the IgM, from nothing to 12.5 to 2.5% again. Less discordance with IgG. I think that's because there needs to be more bands, except for this lab. which called anything with one single IgG band positive. And so you really need to interpret your Lyme antibody in the clinical context of the patient, right? If it's early, they're presenting with acute symptoms, they may very well not have a positive antibody, and you need to sort of put on your clinical hat and treat them. If, on the other hand, they're coming with, weeks to months of symptoms, and you've repeated the antibody a couple times and that the antibody pattern is not evolving, you really need to start thinking about things other than Borrelia burgdorferi. So what to think about if the ELISA and or the IgM is positive, but the IgG Western blot is not? Early disease, as we've said. European Lyme, as we said. Now, there are some tick-borne illnesses called Borrelia Miyamoto and Borrelia mayoni, where there's really no current test. And so, an acute febrile illness after a tick bite, again, you're going to want to treat clinically because doxycycline will take care of any of those species. You want to think about syphilis, high rate of cross-reactivity. You can think about tularemia and relapsing fevers. You can think about things like mononucleosis, HIV, which sort of revs up your antibodies and in a in a global fashion can give you false positives, hepatitis C and hepatitis B. Other inflammatory states. So I had a patient with a positive Lyme antibody, but his hands were incredibly inflamed, and he turned out to have rheumatoid arthritis, not Lyme. And then false positive. So if we go to Texas, where there's very little clinical Lyme in the US, there's about 10% of people who have positive Lyme antibodies, but who've never had any clinical symptoms consistent with Lyme and have had absolutely no exposures, right? So we know that false positives happen, usually the ELISA or the IgM, not typically the IgG. This is just a litany of tests that people will bring to you. So they've had a urine test for Lyme. I've now had people come to me from naturopaths where they stuck their hand in a particular light and were told they had Lyme disease. CD57, very nonspecific, right? All of these tests that people have tried to reproduce and validate and have been unable to do so. So take all of these with a huge, huge grain of salt. Based on available literature, she does not have Lyme disease. She has chronic symptoms and has not developed the antibody. And the other caveat is had not had any antibiotics for Lyme disease specifically that might have interfered with development of an antibody. And so I declined to give her antibiotics. There's a big, social debate of post-Lyme syndrome versus what people are chronic Lyme. Post-Lyme syndrome is where there's more than 6 months of symptoms that interfere with function after you've had documented Lyme disease that was treated appropriately, and there's no evidence of reinfection, co-infection, or comorbid situations. And the reality is that you have Lyme disease, your subjective symptoms, such as fatigue, can linger for months and in about 15% up to a year, despite not having any active infection anymore. Just a word on co-infections. Co-infections with Babesia and with Anaplasma occur in about 10 to 15% of people in New England because they're transmitted by the same tick. In Ontario, thus far, there's been one co-infection of Anaplasma since they've been doing testing. So it's really not common in Ontario yet. Chronic Lyme are patients with persistent pain, neurocognitive symptoms, fatigue, who have no serologic or clinical evidence of previous early or late Lyme disease. So they're people who don't feel good, but who do not have an objective diagnosis. Even for documented Lyme disease, treatment for prolonged courses really has very little data to support it. So a couple of different trials, now smallish trials, right, of 78 and 51 people, antibody positive or negative, who got either standard of care, which is up to 28 days for Lyme carditis or arthritis, versus 90 days of therapy, and there was absolutely no difference between those two groups. There's been a reanalysis of 4 treatment trials where people got ceftriaxone for 3 to 6 months, where really there was no statistical difference in terms of objective markers, neurocognitive testing, or quality of life surveys. Now, these studies were small. I think there's a rare person who probably does need extended therapy. So I had somebody who had endophthalmitis actually to Lyme disease. And based on objective measuring and his vision improving, he actually did need about 12 weeks of therapy. You can have people who have mononeuritis multiplex, and again, they may need longer therapy for symptom resolution, but that's really the exception to the rule. And both of those people had objective markers of inflammation that we could follow. This is just visually what I said. There was really no difference, different study, so they use slightly different drugs, but no difference in your usual year 2 study regimens. So key points, I think Lyme is here, and Lyme is here to stay and will probably keep increasing. Do remember that you can get Lyme in Europe, because if you don't test, you won't pick those people up, particularly with the subtle neurocognitive dysfunctions. Early Lyme disease is a clinical diagnosis, and it should be treated empirically. You do not need testing to prove that you were correct or not correct. And sensitivity and specificity of a 2-tier test increases with the stage of infection. And so the negative predictive value becomes better and better and better the longer people have been symptomatic. And there's really no data to support unvalidated tests or long-term antibiotic use in patients who have negative tests. There's very little data to support long-term antibiotic use in patients who do have documented Lyme disease. The exception can be arthritis, where people can relapse and need retreatment afterwards. So there's the QR code. I don't know if there's questions.
There are a few questions. Thank you for the talk, Dr. Piessens. I'll just read them out to you if that's okay.
Sure.
I have 4, and I'm sure there may be more. But the first question is, will testing remain positive for a long period of time after a patient has had and been successfully treated for Lyme? And brackets, not including those that were treated very early before antibodies developed.
Yeah, if you have developed your ELISA and Western blot, your IgM may wane after weeks to months, but your IgG will remain positive indefinitely, right? We don't know 40 years from now is it still going to be positive, but it does complicate the diagnosis of reinfections, because you can get reinfected with Lyme. You don't necessarily develop complete immunity from acute infection. And once you have a positive antibody, you've taken away that kind of diagnostic criteria of going from negative to positive. So yes, it stays positive, we assume, for life.
Awesome. The second question is, can you get a positive test in someone who is vaccinated? Europe strain of ticks.
So there's no vaccine for Borrelia burgdorferi anymore. It had been licensed 1990s maybe, and then was pulled off the market because there wasn't a lot of uptake. And the vaccine turned a very specific Western blot band positive, but not the rest. And so you could kind of identify those who had been vaccinated. I'm sorry, I'm not remembering the specific band. You could identify those who had been vaccinated versus those who had sort of natural disease. right? But it's going to be a very small group of people who would have gotten the vaccine, mostly in New England in like the early 1990s.
Awesome. The next question is the EM rash generally pruritic?
No, not generally. Not typically painful either. Most people just say, oh, it's there, without a significant amount of complaints. But, you know, I've had all sorts of, it hurts, it itches, it whatever. I'm not sure that the positive and negative predictive value with associated symptoms is going to help you that much. But as a general rule, no.
Okay. And I have one more question from the chat, and unless anyone else wants to shoot some questions away on the chat, but and this I think is relevant to kind of our time right now during COVID. But at this point, should we be sending all ticks removed in the emergency department to the lab for epidemiological purposes?
So I think the public health department would tell you, please don't. You know, I think it's probably useful in the individual who is coming in with a black-legged tick where there hasn't been a lot of Lyme reported. So, you know, somebody who's been in central Hamilton only, I'd be interested in knowing what that tick shows. Or in somebody who has contraindications to antibiotics, but you really want to know what their risk of infection is. My understanding, and I've not talked to Hamilton Public Health, but in Niagara, the folks were kind of saying, well, we're not doing tick testing right now because we can't. We're too overwhelmed. This is something that we're interested in doing again in the future. Right. So I think probably in COVID times, it's not worth it unless you think it's going to change your clinical management.
There's no more questions in the chat, but I had one question, and it may have been addressed before, but I apologize if I didn't. I was just tending to my baby. But
no worries.
Have you, and this is kind of a curiosity question, but have you seen any changes in terms of Lyme disease or, you know, tick prevalence because of the COVID pandemic at all, especially with the lockdown that was had and, you know, maybe people not going out as much? Can you comment on some, you know, if anything, in terms of like an epidemiological thing from a COVID perspective?
I haven't noticed any change in the referral pattern. And when I spoke to public health, they really, you know, they're seeing decreased submissions just again because of COVID and not accepting them as much, but they hadn't seen any immediate change in rates. Now the public health data, you know, lags behind, right? So they're telling you there wasn't a lot of change in rates last summer and fall. They're not going to have a lot of data for this summer and fall. Or not yet anyway. So answer, no, I've not seen it, and I've not heard of it from my public health colleagues either.
Awesome. Thank you so much. I think that's the end for the question. I think Aleem just was saying that in Hamilton, they're not taking any more ticks that are, you know, extracted in the emerge. And he notes that there is an app called etick.ca.
Yeah.
And which might be helpful, as well as a website from hamilton.ca for the public health in terms of Lyme disease and ticks. And Dr. Solano from Mumsy says that she has had many parents at McMaster with tick complaints. So I guess that's been something that's been prevalent in our pediatric emergencies as well.
So many.
And Aleem says that the same. Okay.
Yeah, but I think that the anxiety is really outstripping the reality, right? And don't get me wrong. I mean, I used to see a dozen patients with acute Lyme in Massachusetts a week in July and August. So it's a very real disease, but it has pretty classic manifestations. And so I think people think tick Lyme, and that's really not, hopefully I've convinced you, that's really not it's not as simple as that, right? It has to be the right tick. It has to be there has to be infected itself. It has to be there long enough to have transmitted something. Yeah, and talking people out of treatment and out of antibiotics is a big deal. I think both after tick bite and then in the people who have chronic symptoms and are insistent that they have Lyme disease, even though you have no objective data for it.
There's just chat about amongst our participants, just talking about how difficult it is for convincing patients to not take the antibiotics, or just the anxiety of it.
Yeah.
I had a follow-up question to that. Is there such thing as like doxycycline resistance to or resistant tick or Lyme disease?
So Lyme, the Borrelia is actually incredibly hard to culture and do susceptibility testing on it, right? But if you look at reports like the MMWR or the CDC, there's been no clinical evidence of resistance, and much more evidence that persistent symptoms after appropriate therapy is just because of the inflammatory response that you had and you need time, as opposed to you still have an active infection that needs different antibiotics. In terms of indirect evidence for that, look at the falling rate of Lyme arthritis. So if you get the rash and you get your doxycycline, you essentially have zero risk of Lyme arthritis, whereas in the old days, if you got your rash and we didn't know about Lyme or didn't give you doxycycline, there was up to a 60% arthritis complication rate. So I do think early antibiotics, one, prevent later disease, and two, are still effective if you look at sort of larger surveillance studies.
All right, I think that's the end of our time for our regional rounds today. Thank you, Dr. Piessens, for all your knowledge and the Lyme disease updates. Very helpful. I think my baby's also ready to go to sleep, so good timing. And thanks everyone for coming to our round. Just a quick reminder to fill out the eval, and the QR code is right on the screen there. As well, just to also let you know that October 1st is our virtual 10 a.m. emergency medicine conference. So if you can just save that date, we will be sending more emails regarding the registration for that as well. Last question for like maybe a minute. Dr. Solana just asked, what will Dr. Piessens' opinion about doxycycline in less than 8-year-old patients? Last question.
Yeah, that's interesting, right? I think I'm not a pediatrician. My pediatrician colleagues would say that the risk of discoloration of teeth, discoloration of bones, for example, was really with the older formulations of tetracycline and doxycycline, that the risk is much, much lower. So I think you've got some choices. I think if it's a 4-year-old, I might do amoxicillin. There's good clinical efficacy with amoxicillin as well. If it's a 7-year-old and they really truly are sick from Lyme, or they have aseptic meningitis, I would probably go with the doxycycline. At least anecdotally, people, or in my experience, put it that way, people respond more quickly to the doxycycline. And it seems to me a little bit more thoroughly in terms of resolution of their symptoms. So I think it's a risk benefit. I don't think that age is an absolute contraindication in children anymore.
Thank you.
Thank you for that. Thank you, everyone. Have a good day. Thanks, Dr. Piessens.
Thank you. Bye.
Thank you.